Sue Lloyd. I'm the nurse practitioner for the Child Death Overview process for South Staffordshire, and I'm going to present the Safer Sleep Awareness workshop for you. The aim of the session today is to increase awareness and knowledge of SIDS and your role in the prevention and reduction. The outcomes, your learning outcomes will be to increase professional knowledge of sudden infant death syndrome, otherwise known as SIDS, understand the theories associated with SIDS, build on the professional's knowledge of the guidance in SIDS prevention, and identify and understand the key issues and misconceptions around SIDS. This is the definition of sudden infant death syndrome. It's called the San Diego definition. So this defines a sudden infant death as the sudden and unexpected death of an infant under the age of 1, with the onset of the fatal episode apparently occurring during sleep, and it remains unexplained after a thorough investigation, including the performance of a complete autopsy and review of the circumstances of death and the clinical history. Times an alternate cause of death might be given as unascertained. So this might be used by the pathologist if it doesn't quite meet the criteria for SIDS, but there's still not an exact cause of death being able to be identified. Some pathologists might class something as unascertained, whereas another might classify as SIDS. It's not consistent, and the statistics possibly vary a little bit depending on the classification and the area where the death occurs. That's why we're looking further into this session. We'll look at the statistics on both causes of death in children under the age of 1. So these are the latest figures for the prevalence of sudden infant deaths or unexplained infant deaths in England and Wales. These figures are, the most recent figures are from 2019, but they were produced by the Office of National Statistics in 2021. Obviously, we've said that it is when there's been a thorough investigation into the circumstances of the child's death, and there's been a post-mortem examination that takes time, and there's a coroner's inquest to conclude the most likely cause of death, and that's why there's a delay in the figures. It's not because they're not up to date, they are the most up to date. It's just we can't be expected to be able to identify the cause of death more quickly when there isn't an obvious cause. So you can see here, if you look on the graph, the darker blue line at the top is the deaths that are unexplained, but the two lighter blue deaths include the ones that have been classified as sudden infant deaths and the ones that have been classified as unascertained. So you'll see that those two figures are adding together. Unexplained infant deaths accounted for about 7.1% of infant deaths, giving a rate of a total rate of unexplained deaths per 1,000 live births of 0.27 unexplained deaths per 1,000 live births. Obviously, the birth rate fluctuates year on year, so the exact number of deaths isn't the best way of analysing how the prevalence. The best way is to compare the death rate against the birth rate. So this is why we're describing it per 1,000 live births. This also looks at the prevalence of all infant deaths versus unexplained infant deaths, and the most common period for the deaths to happen. So 80% of all unexplained infant deaths occur in the post-neonatal period. So the neonatal period is birth to 28 days old. The post-neonatal period is after 28 days old, but less than 1 year old. So that's where the majority of the deaths occur in that proportion, and over half of unexplained infant deaths were in males. And those are figures from the 2018. The 2019 figures weren't split yet with the male and female. In fact, that is consistent with all infant deaths. So it's not just in the unexplained deaths that there's over half occur in males. Another thing that we look at the risk factors and prevalence of sudden infant deaths are versus the age of the mother at the time of the baby's death. So the top line in that, which is in a dark blue, that is babies of mothers who are under the age of 20. So you can see that that has consistently been the highest. So the babies with the mother who's under the age of 20 have got a higher risk of unexplained infant mortality. The next one down is the next age group up. So that light blue line, that's mothers in the age 20 to 24 age bracket. And they're sort of so that you can see that the risks of that group as well as maintained significantly above. The sort of the ziggy-zaggy line, that's also a dark blue. That's the mothers aged 40 and over, and you can see that one zigzags up and down more significantly than the others. But maternal age is a risk factor for all infant mortality, and that includes unexplained deaths. So the rate per 1,000 live births in 2018 in mothers aged under 20 was 1.11 deaths per 100,000. So if you remember to the slide before, it was 0.27. So that there's quite a jump, quite significantly above the average. This is the regional picture. So this is to look at the cases locally to us in the West Midlands. So the West Midlands line's the blue again. The England line is the green. So you can see that the rates in the West Midlands, albeit that they've decreased. So there's been a decrease. The most recent figures here are 2017. There has been a decrease from 0.49 deaths per 1,000, apologies, per 1,000 live births from within a year. But actually you can see that the West Midlands rates are still above the average England rate. And these are some figures really locally. So these are the Staffordshire and Stoke-on-Trent figures. And again, these are figures that have been reviewed locally where there's been a conclusion of a definitive cause of death given. So you can see that there's some fluctuation. You've got the Stoke-on-Trent unexpected deaths in the blue and the Staffordshire in the orange, with the grey being the total between the two. You can see that there's some fluctuation between that, some ups and downs, but the general pictures the general picture looks like a slight fall over time. So if we dig a little bit deeper into the deaths of children under the age of 1 who've died sudden and unexpectedly in South Staffordshire, because that's the area that that I work in. These are the 2 yearly periods. So there's the period from 2018 to 19. So there were 4 sudden unexpected infant deaths in that time. When there was further investigation into these, there were medical causes actually identified for 2 of those babies. So one was an undiagnosed heart condition, and the other was an undiagnosed liver cancer. In the other 2 deaths are the ones that continued to be classified as unascertained. There were risk factors present in both of those babies. Baby in a car seat, overheating, unsafe sleep space, unsafe position, smoking in the household. So those are things that mean that there were risk factors. Those deaths may have been preventable. We may have a role in promoting in promoting the healthy behaviours and care and safe sleep for babies, and we could potentially have made a difference to those. In March 2019 to April 2020, there were 3 sudden unexpected deaths in infancy. Of those, so one, there's a remaining police investigation ongoing. So you can see that the time that is taken for to reach a conclusion with these incidents. One was a witness collapse in hospital, so baby was unwell, but wasn't expected to die, was in hospital and collapsed suddenly, and the cause of death was identified to hypoxic ischemic brain injury. So that's where the brain's been starved of oxygen due to status epilepticus. That's an epileptic seizure. So there was a cause of death identified for that baby, even though the death was sudden onset, not expected. And then the other case, so you can see there the one in the middle. Again, that's the case where there were multiple risk factors present for that baby, including domestic violence, concerns for child neglect, parental mental health issues, including alcohol use, unsafe sleeping practices, and smoking. However, the post-mortem was completed and there was no identified cause of death, so they weren't able to attribute the death to any particular cause. Therefore, it was classified as sudden infant death syndrome, or SIDS. So SIDS really is a diagnosis without disease, in that it's where the cause of death is identified as sudden infant death syndrome because no other simple single causes were identified. I think so we're going to talk in a little bit about the theories about sudden infant death syndrome, but it's thought to be a complex interaction of different susceptibilities rather than just one single cause. So these are the theories of SIDS. So you can see that there's research has been ongoing over quite some time. So we'll start with Bergman in 1970, whose theory was multifactorial pathogenesis. So he argued that SIDS wasn't caused by a single characteristic, but by an interaction of multiple risk factors. And then in 1972, Wedgwood agreed with this. The multiple contingency hypothesis, in which he was suggested SIDS the risk was increased when there were 3 overlapping factors that coincided. So the one factor was general factors such as prematurity, sex, overcrowding, poverty. The second, the developmental stage of the child or the age. And the third, the physiological. He highlighted that the risk occurred when the overlap of the various risk factors came together, rather than one single risk factor, and the death would only occur once all of these 3 figures overcame the threshold for survival. So John Emery in 1983, he built on that further, but had some different thoughts about what the proposed risk factors were. So he proposed risk factors of subclinical tissue damage from infection, environmental triggers such as poor nutrition and medical care, and poor postnatal development of reflexes and responses. Environmental triggers in the development period were considered vital, but there was some scope of individual variability there. Then we've got Rognum and Saustad in 1993. So they proposed a 3-hit framework that added possible roles for hypoxic or immunological events. And they contributed, the factors contributing to death were thought to involve central nervous system vulnerability, altered mucosal immunity, predisposing factors such as any genetic predisposition, and then a triggering event such as an overstimulation of the developing immune system, possibly due to a viral infection. And then the best known model is Filano and Kinney, 1994, the triple risk model, or the triple risk hypothesis. So we're going to look at that one a little bit further just here. So this is the triple risk model. So you can see there that you've got 3 areas. You've got the critical development period, that's the baby's age, 0 to 12 months old postnatally, so from birth to 1 year old. You've got the intrinsic risk factors that make that baby more vulnerable. So that includes the male gender, because we've said that there's an increased risk for male babies. Prematurity, any genetic abnormalities, and prenatal exposure to cigarettes and alcohol. And then you've got the extrinsic risk factors. So that's about the environment at the time, or the exogenous stressors. So this is where we talk about the environment. So we're looking at the sleep position, the prone or side sleeping position, bed sharing, over bundling, soft bedding, or face covered. And you can see there that you've got in the middle, labelled in yellow, that's where the baby's at risk of sudden infant death, when you've got an overlap of all three of those areas. So the baby's of the right age, and there's those things that make that baby more at risk, plus you've got the things within the environment that increase the risk, and that's where you have a vulnerable baby. So just to talk a little bit about the mechanism of how a sudden infant death occurs. So that's a bit to do with the respiratory control in hypoxia. So hypoxia is when the oxygen levels drop. So during hypoxia, there's only one neural network that remains active. It's called the pre-Botzinger complex. And this is where it's normal for the baby to sigh or gasp in response to hypoxia, so the oxygen levels dropping, or hypercapnia, which is where the carbon dioxide levels increase. So the normal response is that the baby sighs or gasps, draws in a big breath, pulls oxygen in, breathes out carbon dioxide. But there's just one network available for that. So if the oxygen levels have dropped significantly, there's just the one network that remains active and initiates this response. So any failures, obviously, in its pathway make that baby vulnerable. Pathways dependent on the neurotransmitter serotonin, and there is evidence that prenatal exposure to cigarette smoke affects serotonin pathways in the brainstem. So that's obviously shows how smoking during pregnancy or exposure to cigarette smoke during pregnancy can reduce the serotonin levels and make that baby more vulnerable. Potentially also that this network is at risk due to infection, overheating, or other stressors. I'm going to show you a little diagram now that talks about auto-resuscitation. So that's how I've just explained the sigh and gasp as the baby breathes in and returns to a normal breathing pattern. So if we start off to the far left of the picture, and you've got the baby there, who's been sleeping, breathing normally, has a pause in breathing, so the oxygen levels drop, the carbon dioxide levels build up. So the normal response is that they sigh, they gasp, they arouse slightly, they lift their head, they breathe in oxygen, they breathe out carbon dioxide, and we return to the normal breathing pattern. If you follow through the red arrows rather than the blue, so the oxygen levels drop, the carbon dioxide levels increase, but the baby doesn't sigh, doesn't rouse, doesn't gasp, and that's where the auto-resuscitation fails. The baby becomes short of oxygen, so the brain is short of oxygen, so there's an irreversible hypoxic insult. So that's what means that the brain has had a period without significant oxygen reaching it. It's not something that can be reversed through treatment, and that's when the baby asphyxiated, and that's when we have a case of a sudden infant death. So you can see how a normal baby sleep pattern is for them to have some periods of sighing, gasping, rousing, head lifting, moving, and getting back into a normal pattern. You can probably see how trying to create a deep sleep for a baby who's not easily rousable, how they could miss that response of the gasp and the sigh, and how the missing that response leads to the failed arousal. So just have a think about what we expect about normal baby sleep. So this is a description from First Candle about when a baby dies of SIDS. So it's a sudden event. A light switches off, they stop breathing, and once the switch is flipped, there's no going back. So even with immediate intervention and resuscitation, the baby can't be revived. So on the previous slide, I said that there's an irreversible hypoxic injury to the brain. So it means if you are able to respond immediately, begin CPR, keep the baby's heart beating, put the baby on a ventilator, you may be able to return the breath and the circulation to that baby, but there's the injury to the baby's brain is irreversible, and so the life support has to be withdrawn. And that makes you think about the monitors. So this monitors are sold with the aim of increasing parents' confidence that they're observing their baby, keeping an eye on them. There's various things that are available commercially, including camera monitors. Actually, you're not going to see anything, so you're not going to observe anything on the monitor if the baby succumbs to a sudden infant death. It's not going to be something that you're going to be able to observe over a camera. The sorts of apnea monitors, the little baby with the monitor attached to his foot, or there's the one in the middle of the Lavana, the clip-on monitor that those either we're monitoring the baby's oxygen saturation levels, or we're monitoring the breathing for the baby. So yes, they might detect that there hasn't been a breath, there's been a pause, but obviously there is a delay before the alarm sounds anyway, because there has to be a missed breath for that to sound. The oxygen saturations, the oxygen levels would drop gradually and there'd be a delay before it responds. But actually, even if we did intervene immediately, if it is a sudden infant death, there is no getting back. The risk is that the monitors offer a false sense of security to parents. So next we're going to talk about what's a risk and what's an association, because NICE in 2014 talked about this. So they said an association is a statistical relationship between a factor and outcome. It's not necessarily a cause, whereas a risk infers a cause and a cause and effect relationship. So when we're looking at SIDS, we've got associations. So these are things that are seen in babies that have died of a sudden infant death, but we can't attribute them directly. So smoking, co-sleeping, parental alcohol or drug use, prematurity or low birth weight, and unsafe sleeping practices. So it's not a given. These are things that are associated with babies who do die of a sudden infant death, but it's not a given that smoking, co-sleeping, alcohol, etc. It's not a given that they will go on to cause a sudden infant death. So that's why it's an association. So if we look at the statistics about co-sleeping and SIDS, if we look at the top left corner, so about 700,000 babies born each year in England and Wales, and about half of them will have slept together in an adult bed with either one or both of the parents by the age of 3 months. May have been intended, may not. So the risk of SIDS for all babies in England and Wales is 1 in 3,650. However, if you compare that with the risk of SIDS for a baby who's co-sleeping with a regular smoker, that risk increases to 1 in 900. And then the risk of SIDS whilst co-sleeping on a sofa, or the risk of SIDS whilst co-sleeping after the parent has consumed alcohol or drugs, those increase to 1 in 199. So in comparison with the normal risk, a baby co-sleeping with a regular smoker is 4 times more at risk. A baby sleeping on a sofa with a parent or co-sleeping after the parents have consumed alcohol or drugs increases the risk by 18 times. So you can see where sharing information with parents about how to sleep safely can have a big impact on reducing the deaths. And we're acknowledging, aren't we, by saying that half of babies will have slept together in an adult's bed with one or both parents by 3 months old. It may or may not be intentionally. These are the things that increase the risk. These are when you should be advising parents that they shouldn't be sharing a bed if any of these other risk factors are present.